Good afternoon and good morning to those on the West Coast, and welcome to the webinar. I'm Jody Bennett, GM at CareSafely, and I'll be moderating the webinar. Today, we'll cover the latest COVID-19 updates, liability trends, provide strategies to reduce lawsuits, and the benefits of modernizing the risk compliance process. We will also have a Q&A session following the presentation. There is a Q&A button at the bottom center of your Zoom window. Feel free to start asking questions as we go through the agenda. We'll try to get to as many as we can during the Q&A. We know how busy you are, and we'll respect your time and end at 45 minutes past the hour. Now I'd like to introduce our presenters today. Amy handles wrongful death, personal injury, and employment litigation cases on behalf of senior care companies in Massachusetts and Rhode Island. Rose has over 20 years of experience as an operational specialist providing senior living consulting services for new developments and existing environments. Raj is an expert in risk management and passionate about applying innovative technology to make a meaningful impact on people's lives. Amy, can you begin and provide an update on COVID-19?
Sure. Thanks, Jody. And thank you to CareSafely for having me and for all of you who are attending today. Briefly, just a rundown of the numbers in terms of what's happening with COVID in long-term care. You can see the numbers are high. We have over 142,000 people or senior care residents who have died as a result of COVID, and over 2,200 nursing home staff who have died as a result of COVID. Of the 824,000 plus deaths nationwide, those that are attributable to nursing homes amount to over 17%, which is not an insignificant number. Next slide, please. Go back one. In terms of the legal impact and considerations with respect to COVID, I'm sure many of you have noticed it's changing all the time, but a brief update as of today, there have been over 13,000 COVID lawsuits filed. And you might think that seems somewhat low considering the number of deaths that we have seen in facilities. And I think that there are a couple of things going on there. One is that many states have immunity laws in the form of either legislation or executive orders, which provide a protection to healthcare facilities and long-term care facilities for negligence claims. They're not foolproof, however. Plaintiffs can still bring actions under a gross negligence or recklessness standard, but it's very difficult in terms of the burden on the plaintiff to be able to meet the standard of gross negligence. So these immunity laws may be serving to dissuade some people from bringing lawsuits. The other issue is statute of limitations. Most states, there's different periods of time for which a family or a plaintiff can bring a lawsuit. In many states, it's 3 years. Some states maybe more, some states maybe less. But the point is, it's not as though someone dies from COVID and then the family brings the lawsuit the next day. The lawsuit may not come for another 3 years. So I expect that this number in terms of lawsuits will probably increase over the next year or two. And one more thing with respect to that, there's also a federal immunity provision that's currently being litigated in district courts and appellate courts across the country in terms of whether that federal immunity applies to nursing homes and the COVID-19 pandemic. It may be that many lawyers or many plaintiffs are waiting to see how that sort of shakes out, so to speak, in terms of whether that federal immunity applies as well. In terms of vaccine mandates, of course, this has been all over the news, And as I'm sure many of you are aware, the Supreme Court of the United States has determined that with respect to healthcare workers, vaccine mandates are constitutional. There was a challenge made concerning vaccine mandates for non-healthcare workers or employers having over 100 employees. And the court said that that was not constitutional, but with healthcare workers, it was different. And it was different for a couple of reasons. One is CMS is the one seeking to enforce this mandate, and CMS provides federal funding to facilities. So facilities who are receiving federal funding in the form of Medicare, for example, are subject to this requirement. Secondly, healthcare workers are providing care to patients. Patient care is different than other types of employers where that's not involved. So if you're a healthcare worker in a facility that receives federal funding, the vaccine mandate applies to you. In terms of the OSHA impact, OSHA has several guidelines regarding what to do when an employee contracts COVID or has been exposed to COVID. As many of you probably know, if one of your staff tests positive for COVID or was exposed, then they need to be removed or put on leave, in essence. They cannot be working in the facility. And according to OSHA, the facility may have to pay medical removal pay for those employees who were unable to work due to their COVID status. And that pay is in effect until they're able to return or another criteria is met that is set forth in the guidelines. State by state, the regulations are varying. I would go so far as to say town by town, depending on what the issue is that you're talking about. In terms, for example, here in Boston, where I am now, the city is enforcing a mask mandate in all indoor public spaces, including private businesses. That's not the same in all towns in Massachusetts. In terms of the vaccine mandate, before this ruling came down by the Supreme Court approximately 6 or 7 days ago, there were states who had put in their own vaccine mandate. Last summer, the state of Rhode Island implemented a vaccine mandate for all healthcare workers, and they did not provide, or that state did not provide, an exemption on the basis of religion or disability. And that's very interesting because under employment laws, you obviously cannot discriminate on the basis of religion or disability. So this law was challenged in Rhode Island federal court on behalf of plaintiffs who claimed a religious exemption to the vaccine mandate, and then they were terminated, and they claimed that they were discriminated against on the basis of religion. And the federal court said, no, there's no exemption for religion when it comes to the vaccine mandate of healthcare workers. So that was interesting. And that's an example of one state being more restrictive than what the federal government or what other states may be requiring. And this, of course, leads to staffing. When the vaccine mandate, at least in Rhode Island, was put into place, many facilities, including some of my clients, lost staff as a result of the staff's refusal to get the vaccine. And that puts a strain on facilities. And we all know that staffing, this has always been an issue in long-term care settings. And this sort of layer of COVID and the all of the implications with that has really created an increased strain on facilities. Next slide, please. Thank you.
Amy, quick question for you.
Sure.
As you're going through this, when a lawsuit is filed, like typically, what is the cycle time, I guess, in terms of when it gets filed and time it actually gets resolved? And I'm sure it's a huge variation, but on average, is it a few years, few months, or what's the typical cycle time you see?
The typical cycle time, at least in my experience, is a few years. You may receive a notice of the claim shortly after the death or the incident, or you may not receive it until 3 years later. And then once the lawsuit is commenced in court, then there are certain time periods, in terms of having to affect service of process of the summons and complaint. There are time periods for discovery, which some states have tracking orders to try to keep that within a certain time period. Other states have no tracking orders. And even the tracking orders that are put into place, we're talking about 2 to 3 years. So a lawsuit is not, if something is filed, it's not something that's going to go away 6 months later in most cases. You're looking at a few years.
Gotcha. Thank you.
So looking at the
I have a question that came through. Are state surveyors considered healthcare workers?
That's an excellent question. So the CDC defines healthcare workers as physicians, nurses, and administrative staff, and those generally providing care. I would think that a state surveyor who is going in to, survey a facility and is therefore coming into contact with staff and with patients would need to be vaccinated. But that's a really good point, because it's not as though the state surveyor is a healthcare worker in a facility receiving Medicare funds. But it seems to me that they would certainly they would need to be vaccinated just in terms of the purpose of mandate.
Right. And Amy, I believe it's just like you're talking about how every state is putting their own rules and really implementing that separately and their own, interpreting things in their own ways. And so when you have a state surveyor that is not a federal surveyor, they're going to be held to the state laws and the state rules for them. Just like you have assisted livings who are long-term care providers, but yet they may not fall under the healthcare rule where they have to be vaccinated because they're not receiving federal funds in certain cases. So it's really a very good question. and I guess maybe back to, like you said, localized and statewide, what is going on in your area?
Thank you, Rose. And yes, it just speaks to the ever-evolving law that is happening with respect to COVID. But looking at this next slide, the CDC return to work guidance, many of you may have seen this chart before, but I wanted to point it out because it just shows what has happened in terms of the evolution and change over the past 2 years. So the CDC has set forth certain criteria for whether staff or healthcare workers are vaccinated or not vaccinated or boosted, and then also whether there are certain levels of staffing crises or problems that are present in the facility. Here you can see they have conventional, which means what is the standard or recommended quarantine for someone who tests positive, and generally here they have 10 days. Of course, we recently heard that it's 5 days. So that just goes to show that it's changing. And then there's also the contingency level. So if you find yourself, or if the facility finds themselves in a real staffing shortage, then things that that facility can do in terms of contingency is stop providing elective procedures. That's what a lot of hospitals have done, at least here in Massachusetts. And the reason for that is so that you can provide support to those with COVID, because COVID patients are filling the hospitals, at least here in the Northeast. The governor here brought in the National Guard, and we have National Guard, servicemen and women providing medical care in hospitals. I was actually speaking to a physician who provides care to infants at a major hospital here in Boston. And she works in the NICU, and she described having to give training to a National Guard person on how to resuscitate an infant in the event of an emergency, because that's where we are now in terms of staffing and having to care for COVID positive people who are critically ill. And finally, there is crisis mode. And that is where if you despite having taken all of the recommended measures under the contingency mode, you still do not have enough staff care for patients, then as a last resort, you can have COVID positive employees come into the facility and provide care. There are actually 2 facilities in Rhode Island who are operating in crisis mode now. It's really sort of hard to believe, but that's where they are because you need staff to provide care. If you find yourself in this point, you would want to make a few considerations. For example, you may consider having COVID positive staff work only with COVID positive patients or residents. You might try to schedule the shift in such a way that the person is not providing care to as many people. And you may also consider where the employee is in the stage of their COVID illness. They tend to be more infectious at the beginning of their illness rather than towards the end. So I think this slide is incredibly relevant because it just shows that, you know, we've gone from 14-day quarantine and lockdown to, you know, if you need to have an employee come in who's COVID positive, then you can do it.
Yeah, and just to add to the confusion on this, Amy, it's a very confusing slide for most of us operators in the field to try to interpret, okay, what is safe for us to be able to do and where are we protected if we do have to go to crisis mode? And if you do choose to do crisis mode, who approves that? That's been a big question that's come up quite a bit. And we're not here necessarily to answer that, but that's something that you have to kind of think through. If you're a licensed community in your area, you may want to speak with your state representatives, your licensing board before you go into crisis mode to make sure you've done all your due diligence. And at least that's been the recommendation I've heard in the Texas market from the surveyor teams, is you need to talk to us and make sure before you start doing this. So there's just so many balls in the air to make these decisions, but it's exactly where we are today with the staffing challenges. It's just so difficult to keep our communities operating.
Thanks, Rose and Amy. And it's like everyone is having the same challenges in different places depending on the part of the country. So it's really interesting how complex this has gotten really quickly. I want to expand the conversation a little bit broader beyond the initial conversation was around COVID-19 and patient lawsuits and liability. And I want to bring the employee and the worker, especially the frontline caregivers, into the conversation. And I wanted to present some information from the Bureau of Labor Statistics. The US government keeps track of injury and illness rates. And this data is from 2018, so all pre-COVID. And what it shows is in the senior care industry, 6.1 workers per 100, 6.1 per 100 full-time workers get injured on the job in a typical year. That's twice the rate of someone working in the construction or the coal mining industry. So some really eye-popping numbers. I've shown this data to many executives and legal and compliance officers, and frankly, they're quite surprised by that the nursing and residential care industry has twice the injury illness rate as coal mining and construction. Again, reminder, this is 2018 data, pre-COVID. So my guess is when they start publishing some of this data for 2020, 2021, et cetera, these numbers might be even higher. On the right side, the data is further broken down by the BLS into specific categories of home health on the far left at 2.7 injuries, all the way to the far right with state and government nursing homes and residential care facilities with 11.9 injuries per 100 employees per year. And these are all Bureau of Labor Statistics data that they've been tracking this for 50 plus years or so. So really, really eye-opening to many in the industry. And a lot of this is why we have some of the workers' comp issues and the liability issues that we see coming from the employee side of the house as well. If we go on the next slide, I'll walk you through a little bit more of the details of all this. The top 3, and I'm sure this is not a surprise to you all, but the top 3 reasons for the injuries are sprains and strains, typically back issues, slips, trips, and falls, and exposures to pathogens. And the causes, especially on the sprains and strains, is actually all 3 of them typically. It's typically poor training, poor coaching, lack of right equipment, lack of, most cases, especially these days, lack of proper staffing levels and exhausted employees. And then just employees taking shortcuts because they just don't have the supervision, or you have a lot of temporary employees and contractors in the facility. So as an operator, as a CFO, as a chief compliance officer, legal officer, CEO, and I know many of you are on the call today with those kinds of roles. A few questions y'all may want to ask for your own organization. Do you know your own organization's injury rates and what the causes of these injuries are? Are you actually managing these workers' injuries at the source, meaning before they happen rather than after they happen, and then having to deal with the workers' comp and the insurance issues? And have you benchmarked this to your own peers in your own sector or your own region? So these are some of the things that you all may want to look to consider and doing to understand a better picture within your own organization. How are we doing on employee injury rates? Because all of these things impact not just your workers' comp and therefore liability and lawsuits, et cetera, but it impacts morale, impacts staffing level, and a whole bunch of other knock-on issues that happen when your employees get injured. Next slide, please. This is a little bit more details on the injury rates on the sprains and strains specifically. And almost all of them, if you look at the first two, lower back area and shoulders, that's almost 50% of all the injuries. But if you kind of look to the right of all that, a lot of them are all related to moving residents and patients, right? Knee issues, wrist issues, upper back, neck, lumbar, ankle, wrist and hand, et cetera. So a lot of these issues are frankly mostly related to ambulatory movement of residents and patients. And the cost of the claims can range anywhere from a few $1,000s to about $11,000 to $12,000 per claim. So some pretty significant areas. And there's a lot of good data that's available out there that you can look at to see where those issues are typically. Next slide. One other thing is, as I mentioned, the knock-on effects. If you think about employee injuries, many times it's because of lifting and moving residents and patients. Not only can it potentially injure the employee, but in many cases, it may also injure the resident themselves, right, as part of that transportation that's happening. So, which can also then lead to lawsuits as well. So it almost connects back to what Amy started with in terms of COVID lawsuits. There are other sources of lawsuits related to just injuries from residents as it relates to slip, trips, and falls and other employee-caused injuries as well. So Amy, if I can ask you now to pick up on some of the legal implications of resident injuries.
Yes, thanks, Raj. So I handle a lot of wrongful death lawsuits, and I represent facilities. And most of the most common injury that we tend to see are falls. That may not come as a surprise to those of you joining us today. Another significant injury are pressure ulcers. And in fact, many cases have a fall resulting in an injury, perhaps a fractured hip, and then the resident subsequently develops a pressure ulcer as a result of not being being less mobile. Other issues that we see relate to medication management, assault. That's particularly, that tends to happen on memory care units or with residents with dementia who can sometimes be more aggressive and are not aware of what they're doing. And also failure to observe symptoms of a condition that requires emergent care. Some of the issues that we run into when defending lawsuits that create concern for us is documentation, or I should say the lack thereof. Sometimes there will be an absence of progress notes for a particular time period, and that time period may be a key period in terms of the patient condition. Sometimes we might have just a month of an MAR, medication administration record, missing for whatever reason. And it's not necessarily that the person didn't document, but maybe that document just went missing. And other issues related to just not completing documentation completely or timely. Another issue is that key witnesses are no longer at the facility. Turnover can be an issue, and we may have a case where a CNA or an LPN or an RN even is a key person and they're not at the facility, or the facility is closed. That can be very challenging. And training. In most of the cases, if not all, the plaintiffs in my case will allege that the facility failed to provide proper training to the employee, which resulted in the failure of the employee to comply with the standard of care, which then resulted in the fall, for example. So that is one issue. In terms of strategies for improvement, it seems sort of obvious here, just ensure documentation is maintained. I know that's easier said than done. When you have a nurse on a floor of many patients who he or she is trying to assess, it can be difficult to get the documentation into the computer in time, but it is really critical and important. Also, completing incident reports. So as you know, incident reports are generally completed if there is something like a fall, for example, and these are internal documents. They typically do not become part of the patient chart. However, it's still very important to ensure they are completed and also maintain them. The reason for that is the incident reports tend to have more detail. They will have the names of the healthcare workers or witnesses to the fall. They may have statements made by those involved in the fall. They may show what the root cause of the fall was, and also the intervention that was put into place. Conversely, and this is just an example that I can give you, you may have a fall, and in the progress note, the nurse noted resident found on floor by CNA, reports pain, nurse notified or physician notified, for example. And that's all you have. But then if you go and look at the incident report, you may have a lot more detail where it says resident found on floor with head lying on pillow, appears to have placed himself on the floor, reported pain, was assessed by nurse, all vital signs were normal, range of motion was normal, the family was notified, and you can see there's just so much more detail there. And it's a very different situation, falling out of bed rather than placing yourself on the floor. I've had the case like that. So I know some facilities also worry about maintaining incident reports because what if there is litigation? And the fact is, in many states, there is a quality assurance privilege. So internal incident reports are privileged and are not to be produced as part of discovery. You may have instances where perhaps there's a plaintiff files a motion to compel and there's a court order requiring production of that, but that it would be the rare occasion. But the bigger benefit of incident reports from a litigation standpoint is the fact that it provides us with more information and more facts about who are our key witnesses. What is our defense to this? What did we do to prevent it? What did we do as an intervention? How is it that we acted reasonably? What have you? So maintaining incident reports is really critical. And also similarly, maintaining employee and training records, where you have a plaintiff that says you failed to train your staff, you want to be able to show them that's not true. Here are boxes and boxes of training records related to all of the in-service trainings that we do and the other types of trainings that we do. It's important to maintain those, even if you're not required to for several years, because if there is litigation, they can be extremely helpful.
So what does all this mean from a liability, incident rates, all the things we just talked about the last 15 or 20 minutes? For the folks that are on the call that are more focused on the business side of our operating, it's a pretty bad situation. Liability rates, insurance premiums specifically, have gone up anywhere from 50 to 40% last year. And the indications are for 2022 expect double-digit increases. But not only just the premiums are going up, it's also the deductibles are going up, the caps are going down, and frankly, the number of insurance companies, providers that are in the industry is also declining. So it's a pretty bad picture, honestly, in terms of the insurance aspect of this. And it's purely the insurance guys are making a risk exposure calculation on the industry and specifically the operators as to where they want that profile to be. So all the things we've talked about for the last 15, 20 minutes, it all adds up to your bottom line, which is in areas like workers' comp and insurance rates and other things like that. I know we're running short on time, so we're going to have to quickly move forward. We're going to shift over now and just have Rose talk a little bit more about some of the strategies to reduce some of the lawsuits and issues. Rose?
Yeah, thank you, Raj. And this is not going to be new to anyone. It's just really an opportunity for us to zone in and focus on these key components that really help us to mitigate our risk to the best ability, especially even in today's very challenged times. So next slide, please. So I'm a huge advocate of our frontline team members, our staff, our core foundation. They make or break us in communities. They are everything. So when we invest in training them, it can make all the difference in the world on your retention. It can make the difference on their successes and on your consistency, which I think Amy would agree, consistency is key to keeping things flowing and keeping our risk down. So I challenge you, especially those leaders on the call here today, to really look at your training systems that you have in place now and invest in them. There's lots of tools out there that can help us. CareSafely, of course, thank you for having me today, has the opportunity to provide some of those additional training sources for you that really can zone in on specific roles and responsibilities. So look into that. The other thing about that is it doesn't always have to be a person training initially, but we want to do the follow through on the training. So I have heard from several operators, large operators, that have given me some very scary statistics about the amount of turnover within the first 60 days, not even 90 days of their staff from new hires. And it was alarming to me how high it was. I mean, I'm talking like a 75% or greater. And it just really shocked me to hear that. And it made me kind of wonder why. And as we go through the rest of these few slides that I have, I'll hopefully give a little bit of light on that. Train the staff on expectations. And I mean, be specific, like be very clear in communicating with your staff what your standards are of care. Let's not assume that everybody knows already what those standards of care are. Because as we'll learn in a few minutes here, there's so much of our turnover that happens is a recycling of people too in the industry, which also means they come with a lot of bad habits or habits from other places that you don't want necessarily in your communities. So really be very clear of what your expectations are. Consider mentors. Mentors have been a godsend for me. They also have helped with a retention strategy because people who become mentors are also now trainers and coaches, and there's a sense of pride in that and could really help. But those mentors are non-threatening and they can really be an asset. And honestly, it's such a small price to pay to have a mentor assigned to a new employee where they feel comfortable to ask questions. Coach along the way. Cannot emphasize that enough, and I'll probably say it in a few more slides again, but just be real, be on the floor with them, and if you see something wrong, address it right then and there, and coach along the way on what the expectation is. Of course, in a professional and positive way, and of course, maintaining privacy for the individual, but just when you can do it in real time, then it sticks a little bit better of what that expectation is. And then finally on this slide, just celebrate. Every little step of completion of the completion of training that you can celebrate, it's just like another little milestone that they're making in improving and learning new skills. And it also is something like a badge of honor they can put, whether it's on their name badge or they can put it on their resume now. They've had all this additional training. And we all do better as we're lifelong learners and learning more. We all appreciate those little things that we can add as badge of honors. Next slide, please.
Let me pick this
Raj,
up. Let me pick this up from Rose, actually. Rose talked about coaching, training, and mentoring. I'm going to give you some hard data on this. Based on some studies that we've done in the past, if you just hired somebody and just brought them on and said, okay, just watch whatever someone is doing, just shadow them and do what they're doing, you will get 68% compliance to your safety standards, 6-8. If you provide really good training and then put them on the floor, you'll get 82% compliance to that safety standard. If you do 3 observations or competency checks. And I know many of you do competency checks on an annual basis, but I'm talking about in the first 2 months of their hire, you do 3 observations where you're observing, coaching, and guiding them. You'll get 94% compliance to that safety standard. So there's a huge delta between just shadow training, just watch what someone else is doing and follow them, to actually providing good training and actually observing and coaching them. It's a massive uplift. And so just thinking about that from a mentoring, coaching, and observing, and they all connect up really well. And those first 2 months is super critical. It's also frankly critical for not just the new hires, but the experienced staff, because many times it's the experienced staff that are teaching the bad habits to the new staff, and they're taking the shortcuts because they're so, short-staffed, if you will. So it's not just the frontline folks that need this kind of coaching and checks. It's the experienced staff as well. Rose?
Yes. Thank you, Raj. And thank you for emphasizing that with some real data versus just, our own experiences that we deal with day in day. And so managing turnover, we hear this all the time, and especially when we're looking at our bottom line, we're like, oh my gosh, we really got to get a handle of this because it's just killing us when we have such high turnover. No matter what we try, sometimes we feel like we just want to put our head in the sand because it's just like, oh, what is the answer? And I'm not here to tell you exactly what that answer is, but I want to kind of give you at least some points of keeping it simple. Like, let's get back to the basics on how we're dealing with human beings and other humans that are working and caring for other humans. And so we have that ability to communicate and connect with each other in a humanistic way. And sometimes we maybe just have to step back from all the responsibilities and the pressures as leaders that you face every day and take a step and a breath and think, okay, how is this individual, this staff member that I'm working with, this team that I'm leading, how are they feeling today? How are they doing? How are their loved ones? We're all on the same team here. We all have the same goal. So just a little bit of information. Employee turnover creates the largest risk. Top reasons people leave is due to lack of respect from managers and lack of teamwork from coworkers. And it's expensive, right? It's significantly expensive. The dollars on recruiting that we spend, on training, on the injury costs from when those things happen, and much more, those really affect our bottom line. And when you calculate it, it's over 20% of the salary of one individual that you're having to replace. It's quite significant. There was an on-shift survey in 2020 that showed that 87% of new employees come from other senior care organizations, which I found astonishing. I was like, wow, I didn't realize that we're pretty much recycling our own people over and over again. So if we can focus on keeping our staff versus allowing them to just recycle in the system, then maybe we can do that by better understanding why they're leaving in the first place and maybe addressing that. So stay connected with them. Another report I found was from the Harvard Business Review, and the article is titled, "Build a Culture That Aligns with People's Values." And they highlight how 46% of employees want a place where they can be themselves. Another 46% want to have a positive impact on society, and 65% they would deal with lower pay than deal with a bad workplace environment. So what that study shows me is that culture is very important, but it's an expectation. So we should definitely already have that in place and not be having to drill down that, oh, we have a great culture. Really, is it truly meeting these needs that individuals have? Which I have to say, I think most of us probably feel like we would want those things too. So listen and act on concerns. I would say survey your staff. It's an easy thing to do. Most of us have systems where we can easily just send out a survey. Now with Google and other things, you can do a real quick link, and you can survey them and get some information. Find out what is important to them, what really matters. We're in the business of trying to figure out, oh, they want benefits, they want medical, they want that. Let's drill down a little bit deeper for the frontline staff, particularly. What benefits really do matter to them? Maybe it's more flexibility in hours related to the pandemic because kids are fluctuating between virtual learning and in-person learning, and they were exposed or not. There's a lot of variables going on. in McKnight Senior Living, they featured a study that was done by the Texas Assisted Living Association on Workforce Development Committee. And that study was titled Exploring Retention, which they surveyed over 227 caregivers and 164 managers. And what they found was that what caregivers valued most was not in congruence with what leaders believed. So although they all agreed that pay was a high motivating factor, which we know that that's a challenge that we're all dealing with right now, the majority of caregivers are more likely to leave due to feelings of disrespect from management, and they would take a pay cut for a better working environment. So it's a great opportunity to check in with our leaders, touch base. Leaders are feeling the stress, as I mentioned. They really are feeling the pressures. They're working the floor a lot. They're trying to handle as much as they can handle. But if we check in with them and see, hey, how are you doing with your connection with the staff? How are you feeling about your communication with the staff? Or are you feeling like you're too stretched and stressed that maybe we need to disconnect and do a little refresher on some leadership coaching and training opportunities? Sorry, my slide switched on me. So one final thing is leadership training, just identifying those sensitivities, and then coach in real time, just utilizing the opportunities to coach in real time, which I've said before, and stay flexible, of course. We're just all having to be flexible. On this slide, I would love for Amy to maybe help support, and I'll be very quick on here, but I document is what I heard her say earlier. Document accurately. I would emphasize document facts only, teach your staff to document facts, but any communication that you have, whether it's a situation with a resident who you see is declining, you're the professional, you've seen the situation, the family member or the resident, they've hired you to take care of them and to communicate this with them, and you have a communication with them early on. Document that communication and keep it handy, because later when something does happen, you can reflect back, like, we had these conversations, I'm trying to emphasize this again, we put these things in place, and then you can also have your follow through and your final resolution documentation. You just keeping those facts at real time when they happen will keep things so much smoother and simpler in the future should you ever have something come back. Amy, did you want to add anything to that?
Yes, I did. It's keeping those facts in real time is exactly right. Documentation is so key. I'm reminded of a case that I had where the allegation was that the facility failed to observe signs of a condition requiring emergency care. And during this 3-hour time period, we had a complete absence of progress notes. And so what we had in place of that was a complaint filed by the plaintiff with all sorts of, horrible allegations of alleged neglect of care and different examples. Unfortunately, we don't have any documentation to combat those allegations, to sort of fill in that gap. And the nurse in that particular case advised that she was not comfortable with the computer, so she wasn't that great at doing progress notes. And that's what we have. And so it sort of goes back to this, the idea of training and coaching and how that does play into documentation and eventually, potentially litigation.
Yes. And
Sorry,
the
Rose,
investigation.
I hate to interrupt you, but we are right at time. And I just wanted to see if everybody could stay on an extra 10 minutes. We do just have a few slides left, and we do have some Q&A, and I can follow up with everybody and get them answers to all of their questions at a later time. So if you could stay on an extra 10 minutes, that'd be great. So thank you very much. Go ahead, Rose.
Well, everybody's time is extremely valuable. So sorry, we got in a soapbox and kind of can go on and on.
Well, we're all excited. We're really into this stuff. So
yeah, well, it's so critical. And, the complaints part, in the real-time documentation of that, just keep it basic. We don't have to get too extensive on that. We just need to document what really happened, what we know is fact, who we spoke to, those connections, the names of people, the times, the dates, So, and just keep it together. I think that's been the one thing I've seen failures on both employee issues as well as with resident family concerns, like, you know, from the family member that spirals in and says everything is wrong, and we have everything documented, like, well, no, we've investigated and our actions are in place and we're good. So it just keeps us a little bit more confident in responding to those things. My final slide was just on communicate. I really, from my own experience, have found, and I hope Amy can maybe share from the legal side, that communicating openly with family members, with employees, and being, you know, real about situations is very important. And we've really shied away in some respects. I guess in my time doing this over 20 years, you know, I remember the days of saying, no, don't say anything, you know. But no, I mean, we have to be able to share the facts of the situation, particularly when you're dealing with somebody with dementia that's advancing and their risk levels are increasing. Like, we need to set that expectation and have those open communications with the family members, and have, you know, maybe the physicians or the clinical experts support us while we're presenting that information, and then we document that. Because these things are going to continue to decline. We know aging with chronic illnesses, we're going to continue to have issues pop up, and risk factors of injury are going to continue to increase as those comorbidities also continue to decline. So it's very important to communicate, and communicate often, and not shy away from having that communication. And when something does happen, because it will, call and communicate that, because the worst thing is to have them say, well, nobody ever even called, nobody cares, and then the whole negative thought process just goes on and on and on, and then we get into higher risk of litigation. Am I right on that, Amy?
Yeah, I was just going to chime in. That's exactly right. In so many of the cases that I handle, the family is upset because they feel like that their loved one was not cared for. And the reason they feel that way is because no one kept, at least they allege, no one kept them informed as to what the resident's condition was. So not only communicating with family, but as you mentioned, documenting it as well. When you document your communications with the family, you have something in the record to refute the allegation that the family was not kept informed. So if you have, whether it be a phone call or a personal interaction or Skype or Zoom or what have you, it's great to document that and document what the family says. For example, is the family in agreement with the care plan? Put that in the record so that if they bring a lawsuit later and say that the standard of care was not met, well, the family was in agreement with the care plan at the time. That can be helpful. So yes, document and communicate with families.
Well, thanks, Rosa. Amy. And I'll just take like one quick minute or two just to talk a little bit about, I know we're running really short on time, but just in terms of modernizing your risk and compliance process itself. Many of you will probably have an EMR system. Many of you will have a digital financial and accounting management system, et cetera. So when you think about your quality, safety, and compliance processes, most of you, my guess is, are using paper, spreadsheets, emails, hallway conversations to manage an entire process. And one of the things that we've seen in the other industries that have been doing this for 20 plus years is put a digital process together, digital software to manage the entire quality, safety, and compliance process. Some of the key benefits of something like that are obviously cutting the admin time by at least 40 to 50%. Identifying your risky staff and locations before the incident happens, because you're actually able to see during the coaching and all those other aspects that are digitally documented, you can benchmark and identify your high-risk employees and facilities. It enables consistency across all your locations, especially if you've got more than 5 or 10, 20, 30, 50 locations. We've got clients with hundreds of locations. They simply cannot ensure that their safety standards are applied throughout all the different locations at every shift, every location. So a digital standard of doing that, digital management system to manage all of that, is something that's really important to consider. Next slide. Just a quick introduction to CareSafely. We'd be happy to do an offline conversation later. But we built a system specifically for the senior care industry, a system that's software-based, that's on an iPad, that enables you to assess all of or any of your quality, safety, or compliance risks. We have our own library with quality and safety assessments, and our clients can upload their own assessments onto our platform. The ability to add photos, notes, and attachments, all the different things that you want to have a really robust risk assessment on any topic related to your operations. Even more important than that, because many folks do that on paper, is the Achilles heel is when you've identified a risk or a gap, a safety gap, making sure it gets closed, making sure there's a corrective action plan that actually gets closed off is always where it all falls apart. And when you have a digital system, you can actually manage the workflow and make sure all those corrective actions have actually been, you can track them, manage them, and make sure that they're closed. So it's super important that not just you identify an issue, but you actually close that. And a digital system enables you to do all of that and keep track of everything by facility, by employee, by region, et cetera. We mentioned earlier about the notion of competency checks and staying compliant. A system like ours enables you to actually, as you have new hires or employees, make sure that they're actually following your safety standards on any topic that's important, whether it be simple as PPE and hand hygiene to more med pass and more important, more critical, life critical areas as well. And then finally, if you have a large organization, anything more than 5 or 10 locations, the ability to ensure that you have a real-time active view of your entire quality, safety, and compliance process at the corporate level, regional level, and the facility level becomes really important. You can't rely on spreadsheets and emails anymore at that level, just like you can't rely on paper-based EMR or paper-based medical record system. So a system that's thoughtful in its approach to managing the entire quality, safety, and compliance is something that you all may want to consider, especially if you're a mid to larger size organization. With that, I think we're going to turn it back to you, Jody.
Yes, so we are not going to have time for the Q&A, but I do want to thank everybody for staying on longer. We will answer every question that came through, and we will provide that to you. Another question, we will provide the slides to you after this event. But on behalf of CareSafely, we want to thank you for joining us today, and more importantly, for all the hard work you do every day to keep the residents and employees safe. There will be a short survey following this webinar, and would appreciate it if you can take a minute to answer a couple of questions. Once again, I want to thank our panelists, and I want to thank everybody for joining us today.
Take care, everyone. Stay safe.
Thank you, everyone.
Thank you.